I was told always that you should start off a presentation with a story, and I'll give a story about rock star Dr. Timmerman. So, about 5 or 6 years ago, I was at a meeting, CyberKnife meeting in California, and I was the only non-radiation oncologist there. And when someone heard that I was from UT Southwestern, they said, and it was a group of them, they came up and they said, "Oh, do you work with Bob Timmerman?" And I said, "Yeah." And they said, "Wow, he is a rock star. Can we get your autograph?" No joke. And the problem with Zoom is there's no laughing. But but I was really fortunate to get involved with Dr. Timmerman. So pretty much everything I know with regards to radiosurgery is from Dr. Timmerman. So I was asked to speak about how we treat AVMs, and for what it's worth, and you'll see my slides in a minute, where we had up until about 2 years ago 63, 64 patients. We've now treated upwards of 75 patients since 2012, and our service, our hospital, our university is well known for cerebrovascular neurosurgery. My adult partners do a lot of management and treatment of patients with AVMs. And then here at Children's, we see somewhere on the order of 10 to 20 new patients with AVMs a year. It's for whatever reason, AVM practice, especially for as pediatric patients go. But as far as what I'd like you to take home with regards to AVMs, they're relatively rare. There are multiple options for management. And when we consider management of these congenital abnormalities, with an incidence in the United States of over 10,000 patients being diagnosed a year, we consider their age, their neurologic condition, what type of symptoms they may or may not have. Obviously, in this day and age, as imaging, CTs, MRIs are being done for multiple different reasons, we're finding AVMs incidentally. What types of management the individual has had before. Obviously, whether someone has had will affect the decision, as we'll talk about, with regards to radiosurgery. We want to consider what the appearance of the AVM is, its volume, its morphology. Is it tight? Is it loose? Where the AVM is going to be. And we want to be able to estimate what the surgical risks are. Surgery, open microsurgical excision, remains the gold standard to which everything is measured. And at least as far as we are concerned in neurosurgery, there are multiple different stratifications for defining risk in patients. And we also want to know if the AVM has aneurysms associated with it, in particular, feeding artery aneurysms, and I'll talk about that. So to refresh yourselves of some pathology, AVMs are congenital abnormalities for the most part. Individuals can develop AVMs postnatally, particularly if they have Osler-Weber-Rendu or hereditary hemorrhagic telangiectasia syndrome. But for the most part, they're isolated, they're congenital, and they're a cluster of an abnormal number of blood vessels in an abnormal location. And the key to AVMs is the fact that there is no intervening capillary network to dampen pressure from the arterial to the venous system. And as a result, because we have abnormal blood vessels that have weakened walls, we have an absence of a capillary network. These AVMs, these blood vessels can leak and hemorrhage. And then anywhere from 1 to 5%, depending on who you read and who you believe. So it's not, there we go. I mentioned grading scheme, and the grading scheme, there's a one general grading scheme in neurosurgery that we use. It has been refined over time, but people talk about this thing called the Spetzler-Martin grading scheme. And Robert Spetzler was a neurosurgeon who just recently retired in the last 2 years in Phoenix, Arizona, and his protege, Neil Martin, who is still practicing in Los Angeles, in the late 80s, early 90s, developed this risk stratification that uses size, location, is it in an eloquent area or non-eloquent area, and then venous drainage to come up with a score. And then up to a 5 or a 6, where it's a complex AVM. And in fact, 6 is considered inoperable. So size, things less than 3 centimeters, between 3 and 6 centimeters, and greater than 6 centimeters. As I said, eloquence, is it in eloquent brain or non-eloquent brain? And then is the venous drainage deep or superficial? And so this is an example of an angiogram we use. This is a AVM of the posterior fossa. The nidus size is under 3 centimeters, so it gets 1 point. The venous drainage is superficial, so it gets no points. It's close to the brain stem, so that's considered somewhat eloquent, so we get 1 point. And so we have a Spetzler-Martin grade 2. And so my colleagues that like to do a lot of cerebrovascular surgery think that this is a patient who is optimal for open microsurgical excision. And when we're talking about open microsurgical excision, I wouldn't be a surgeon if I didn't show you what an operation looks like. This was a patient I operated on probably about 15 years ago with a hemispheric AVM. And you can see it was after a rupture. So the brain is edematous and red. I certainly wouldn't try this again. I usually let the brain settle down before attempting an operation, but this child was having difficulties. I went to decompress the child, bleeding ensued, and so I ended up having to take out the AVM same sitting. As a surgeon, we're always looking for ways of doing things better. And that's where we come to radiosurgery. And as you all have probably heard and may know, that we learned in the 60s and 70s that radiation does affect, for whatever reason, the abnormal blood vessels of an AVM, and it tends to affect them differently than it would normal blood vessels. Now, I was classically taught that radiation causes intimal damage to an AVM blood vessel. It causes the blood vessel to thicken, eventually narrow, and self-obliterate. I've now been told by Dr. Timmerman that what really is happening incites an inflammatory response in the tissue around the blood vessels that swells and chokes off the AVM. I suspect that there's a combination of that. What's interesting is that Raymond Shelberg, who was a neurosurgeon at the Harvard affiliated hospitals, is the one who actually came up with utilizing radiation for AVMs. And he did so in the 70s, and he had some moderate success. 20% of patients actually had their AVMs obliterated, but he didn't do great. And that was, again, because he's providing radiation to the entire brain. He was limited in dose, and he actually didn't know what dose to really try. And over the course of the 70s, started looking at using radiation for treatment of AVMs. A group at Lawrence Livermore Laboratory in upstate California, and ultimately associated with Stanford, started to use helium ions to treat AVMs in the late 80s. And then you have Dr. Lexell. Dr. Lexell and his protege, Dr. Steiner, started to utilize gamma knife for radiosurgery in the early 70s. And then in the late, in the early to mid 80s, we saw a group out of Gainesville, Florida, start to treat AVMs with a linear accelerator, and that's also taken off. So this is, as I give this talk to my colleagues in surgery, again, what we used to do, we used to leave a hole with radiation, with open microsurgery, and now I've converted, and I almost never do open surgery on AVMs. I gave that up about 2 years ago after I hired another partner to do that surgery for me. And now I pretty much work for, at least as regards to AVMs go, with this gamma knife. And that's because, as I just explained to a patient about 30 minutes ago, it's a non-invasive alternative. I can do this procedure in an outpatient setting. I can still wear a coat and tie. And I believe that I can avoid the majority of risks associated with traditional open surgery. So this is a picture of Dr. You've probably seen him. Again, he was a neurosurgeon working in Stockholm and then also in Uppsala in upper Sweden. And he studied under a prominent neurosurgeon named Herbert Oliva Krona. And what he found when he was working with Dr. Oliva Krona was they hurt a lot of people. And so Dr. Lexell was on this lifelong quest to do things in a minimally invasive fashion. And so you see here the Cartesian coordinate device that he used to fix to the brain so he could localize lesions in the brain in an easier fashion and do things with less mortality and less morbidity than Dr. Oliva Krona. And so Dr. Lexell actually traveled to the United States and he worked with a neurologist and a neurosurgeon in Philadelphia. And he developed, again, and you'll see on your left side, this frame based on Cartesian coordinates to localize targets within the brain so he could make lesions in them. That's what neurosurgery was. It was treating psychotic disorders. It was treating tic douloureux or trigeminal neuralgia. It was basically doing things to make lesions in the brain to make people suffer less. We weren't really taking out a lot of tumors and doing things like that at that time. So Dr. Lexell has this young resident, Dr. Steiner, and they decided they wanted to try to treat AVMs. Dr. Steiner had read about what Dr. Schellberg was doing in Boston. Somehow treat an AVM with your Cartesian coordinate frame. And so what they did was, instead of a probe that they would pass into the brain into a target, they connected on this probe which directed proton beams in the head. So this was their earliest, I don't even want to say gamma knife, but this is what they first did, and this is how the term stereotactic radiosurgery was coined. And this is Dr. Lexell treating the first patient with an AVM in the early. And you all have already heard about the gamma knife. Basically, Dr. Lexell felt that the Linac was too bulky He didn't like the probe that I showed you, so he ultimately redesigned and developed the Gamma knife, which he felt was better suited to treat tumors and vascular malformations, and first introduced it in 1967. Ultimately, it made its way across the Atlantic in 1987. You all already know that. And as I mentioned, radiosurgery exploits a number of effects within the blood vessels. It also uses smaller volume. It exploits the fact that smaller volumes of normal tissue can withstand much higher doses of radiation than larger volumes. When we begin to look at different factors that make AVM obliteration successful, and again, I'll get into this in just a minute a little bit more, I do believe we can cure the majority of smaller lesions, smaller AVMs. People talk about 3 centimeters. We here in Dallas, we use volumes. And so usually anything under 10 cc's we'll consider small, really under 8 we consider small, and we'll treat with 1 fraction. Anything over, we start to talk about our fractionated techniques. Don't like to go below 20. I'll occasionally go to 18, but my preference is always to treat at 20. So if we have an abnormality that is, say, 9 or 10 cc's, but it's in a critical, eloquent location, we actually will say, you know, if this were in the frontal lobe, I'd give it 20. Here, I can't. So you know what? We'll stage it. But 20, and when we stage it, my goal is always to get to 20 gray. Again, I'll touch on this in a little bit. It has been the main point that my partners who are doing open surgery and the grief they like to cause me in discussing with patients the benefits of open surgery versus radiosurgery is the fact that rid of it all in one shot and make your hemorrhage risk go away immediately. Whereas obviously with radiosurgery, at least what's written in the literature is it takes up to 3 years for it to work. During that period of time, you can still have a hemorrhage. We call that a latency hemorrhage. The overall risk of a latency hemorrhage is estimated to be about 1.3%. And up until last summer, I used to tell people, even though I did not believe that radiation protected you, and there are some people that do believe that radiation protects you from latent hemorrhage, we hadn't had a hemorrhage. Well, last summer we had our first, and it is not pleasant. This is kind of a gold standard paper to me by the group out of Pittsburgh and written by Dr. 1,000 patients with AVMs. And this is kind of where I came up with my 20 gray. They used a mean dose of 19 gray. And after this paper, I really came up with, I really want to be able to hit 20 for everybody. And they looked at their success, and they had very good success with AVM obliteration. And they noted of their treatment morbidity, a complication rate of about 8%. And that 8% was broken up into new focal neurologic deficits, seizures, headaches, and even radiographic abnormalities that are asymptomatic. And they classified their complications as minimal, mild, and disabling, and even fatal. And the majority of patients, if they had improved. And they also found that no patients really had cognitive or neuropsychologic deficits. One thing we have found at least in the literature, is that the incidence of complications may be related to AVM location. Eloquent areas like the thalamus, basal ganglia, brainstem seem to be prone to more deficits. I wonder if that's, I'm not quite sure that that's really tissue related, but maybe simply related to the dose. And then obviously volume has an effect on complication rate. The literature will say that was treated with a solitary dose of gamma knife radiosurgery will obliterate within 3 years. As we'll show you here, I think that success is better, and it can be achieved, I think, with carefully deciding who you're going to treat and who you're not going to treat. So obviously our results are a little biased, but effective obliteration rates right now in the literature, you would consider success of about 85%. You can retreat these patients and have comparable success rates with low incidence of complications, and I'll show that as well. So basically, when I look and when Dr. Timmerman looks, and now Dr. for radiosurgery, should we consider this patient for open microsurgery? We look at several factors, and I've kind of gone through them earlier: the bleeding history, the age of the patient, existing comorbidities, the location, volume, angiographic architecture, is it compact, is it loose, and then the clinical symptomatology. And then again, I think that in this day and age of providing highly reliable care that is safe, timely, effective, equitable, efficient, the last thing that we need to consider is patient-centric. And you can't take the family out of the equation. And you have to consider the patient and their circumstances. Are they going to come back for follow-up, or are you going to lose them? I have to think about with the children that I may not necessarily think about in the adult population. So once we decide in Dallas to treat a patient with radiosurgery, all our patients, and it may be 18 or 19, are going to be done under general anesthetic. And even our teenagers, I think that it is it's safer, it is easier on the patient, and easier on the physicians. And so why do we not? We've had one patient that Dr. Timmerman convinced me to do under local anesthetic, and she started having pseudo seizures until we had to kick the mother out of the room, and they quieted down. And after that, he said, "Brad, you're right. I'll never general anesthetic again." So all our patients are anesthetized with a pediatric neuroanesthesia. So they come in around 6:30 in the morning. They meet with the anesthesiologist. They get put to sleep. Then Dr. Timmerman and I and Dr. Wardock will put the frame on. We do our bubble measurements. We do our post measurements and pin measurements. And we travel now to MRI. And obtain a contrast-enhanced three-dimensional specific volumetric MR. These days, we're also going to CT angio, as we've got a study looking at whether or not we can avoid the use of digital. Right now, once we finish with those, we go up to angiogram and obtain a second study, or now third if you include the CT angiogram, but we do a formal angiogram with the frame on. Then we come back down and we localize the AVM after having the MRI and the angiogram merged using Gamma Plan software. We determine the volume and we decide on the appropriate volume and then delivery with multiple weighted shots. We try to keep the time under an hour. But we won't we won't sacrifice a good plan for just efficiency of time. The child is then brought to the Gamma Knife where the radiation is delivered. Once it's delivered, we take the frame off, we wake the child up, and they go home. So as of about 2 years ago, well, I've been doing this for 14 years, not 12 years. As of about 2 years ago, when we looked, we had treated 63 AVMs in almost 60 children over the course of 12 years, and had lost 3 patients to long-term follow-up. And of those, there were still 19 AVMs who data is a little off. Subsequent now, I've got probably the same number of patients in their latency period, but we're now over 75, close to 80 patients treated. When we look at our demographics, they're really not that much different here in Dallas compared to what's in the literature. Our mean age of treatment is around 13, with similar gender profiles between males and females. The vast majority of our patients have presented with a hemorrhage. Next, most common are seizures, followed by headaches, and then several incidentally identified AVMs, say after head trauma. And this brings up a question. You know, there are studies in adults that show whether the asymptomatic AVM should be treated or not. My own bias is in children. We still recommend treatment of the vast majority of AVMs, unlike in the adult situation. Gamma knife radiosurgery was used as the sole treatment in 52 out of the 63 AVMs. So that meant that 8 of the AVMs that we treated up until 2 years ago were partially treated by myself or my partners with open microsurgical excision. So we left some nidus. So in probably 30 patients, 8 patients required additional treatment. Those families all opted against having us reoperate and went for gamma knife radiosurgery. One patient and previous gamma knife radiosurgery by Dr. Steiner in Virginia. 2 patients that were treated at the time were staged. They had large AVMs that we shrank with CyberKnife, and this was intentional. We knew that, and generally we don't treat to cure with CyberKnife. My own personal goal with CyberKnife is to treat to shrink and then use a single stage gamma knife to obliterate it. And then 2 patients that we've treated, we had to retreat after initial gamma knife radiosurgery. Our mean volume was about 4.6 centimeters, but it ranged anywhere from 2.5 up to. Location was varied throughout the hemispheres, midline basal ganglia and posterior fossa. When we look at the complexity of lesions, the majority of our lesions were moderate complexity, so Spetzler-Martin grade 2 and 3. And then here you see our mean margin have ranged from 14 to 22. And so again, over time, I've really gotten, I've fixated on my 20 number. Generally, I will follow patients every 6 months with an MRI after their radiosurgical treatment. And I will obtain a conventional angiogram to confirm obliteration once the MRI suggests that the AVM has been obliterated. Tell on an MRI whether the AVM has been obliterated or not. And so rather than wait 3 years, I now will look with an angiogram at 2 years. If they still have AVM, I'll wait till 3 years, re-angiogram them, and then consider retreatment with radiosurgery or with open microsurgical excision. And when we initially looked, our obliteration rate with just a single shot of radiosurgery was 90.9%. And then if we included the patients who we had to retreat, our obliteration rate went to 93.2%. Our current obliteration rates, if we look at our entire series of over 93% with the first treatment. And then retreating, we're getting close to 97%. Our mean time to obliteration is around 25 months. I'm not sure how well I can use that since, you know, I'll wait on some people on their MRIs to 2 years or 3 years, but by and large, I tell families in children, it's gonna be about 2 years that you can expect an obliteration. We now have one patient whose AVM obliterated within 6 to 7 months. I can no longer say that we've not had a hemorrhage after treatment. We had our first latent hemorrhage last summer. That patient, however, did not have single fraction gamma knife radio, had staged CyberKnife therapy, and had a hemorrhage. But nevertheless, it was radiosurgery, it was an AVM, and I do let families know that we've had one patient that has had a hemorrhage. It was significant. The patient has improved, but has some significant impairments following such. When we look at our initial failures, the very first patient we treated was a large volume AVM. Again, it was over 10, it was 10.2 centimeters, but it was also in somewhat of an eloquent cortex in the thalamus. And so we gave him 14 or maybe 16 gray, and it did not obliterate at 3 years. We subsequently treated that individual first staged patients that Dr. Timmerman did here in Dallas, and eventually was obliterated, but he was an early failure. We have had a patient with bilateral thalamic AVMs who had recurrent hemorrhages that we treated, and while the AVM shrank, they did not go away. What is interesting is she may not actually have AVMs. She may have some sort of vascular proliferative disorder, which is actually starting to respond to some chemotherapy. We've had one patient with an AVM in the cerebellopontine angle. It was a small AVM that required retreatment, but it did not go away after the first treatment with radiosurgery. And that's where Dr. Timmerman has told me that AVM space tend not to do as well as those within brain parenchyma. And then our last failure in our early series was this patient I mentioned a little bit ago, who was treated by Dr. Steiner in Virginia, was treated with radiosurgery, had had embolization actually before, had a stroke because of the embolization. Then Dr. Steiner treated him. He had recurrence of the AVM, at least that was what was told to us. It turned out he probably didn't have a targetable lesion because of the embolization. Had additional embolization 2 years prior to seeing us in San Antonio. And we elected to treat him. We found that there was some residual AVM. That AVM, actually, when we put the two studies side by side and on top of each other, it turned out that the area that we treated had been obliterated. The area of what was deemed residual or recurrent AVM was not there at the start, and again, probably was related to previous embolization. So at least for us, we generally will not treat an AVM after it's been embolized. We've talked about doing embolization at the time of treatment so that we would at least have a target, even though it would be embolized. Most of the embolization particles are temporizing, and so they're not permanent. These AVMs will recanalize any. If we look at our response, clearly we do better when we treat over 18 gray. The location didn't really affect our response rates. Complexity, obviously, the less complex an AVM is, the better it responds to radiosurgery. A lot has to do with volume and dose. And then when we look at our complications, two of our patients developed seizures or worsening seizures during their latent period. Both of these patients, their seizures resolved once their AVM was completely obliterated. No hemorrhage, and we've had treatment failure of about 9.1%. And this, our results stand up to those previously reported in the literature. And basically, in conclusion, we believe that gamma knife radiosurgery is a valuable option, especially for pediatric AVMs. It's generally safe and well tolerated. We believe that our data compares favorably, if not more favorable, than what's reported in the literature. My bias is really to give everyone 20 gray. We look at the size, complexity, and location, but volume size is really what we consider most when trying to decide whether we can treat this in a single episode or whether we need staged therapy. So with that,
all right, thank you, Dr. Weprin.